Hi, I'm Dr. Manjunath. I'm a pediatrician and a allergy specialist based in Bangalore. Today we are going to look at MART therapy. What are the latest evidence and the recommendations what we have today for 2025? Before we go any further, just make sure that you hit that subscribe button, but at the same time also make sure that you like and share this video as much as you can. It is going to really keep me motivated to do things any better. Well, in this talk, we're going to address the MART and its rationale, explore the pediatric specific evidence, implementation strategies comparing MART versus the AIR therapy, and the GINA 2025 recommendations. When it comes to the pediatric asthma, there are a lot of difficulties what we all go through. Maybe from the diagnosis, then the inhalation, motivating a patient to start inhalational devices. And then there is always that risk of patients going back to the MART therapy, going back to the syrups, alternative forms of therapy. And when it comes to the treatment part of it, there are syrups, ICS, SABAs, ICS SABA, ICS LABA, ICS LAMA, ICS formoterol. On top of all that, you have the Montelukast levocetirizine combinations. But we will start with building a case. Well, here we have a 6-year-old boy. We'll call him as X or Liam. And the doctor, what we have is Dr. Expert kind. He decides to start salbutamol, after making a diagnosis of asthma for the 6-year-old boy who has been recently diagnosed with asthma. He decides to start off the medicine which he knows, and that is the salbutamol. The doctor is very happy that he has started the inhalation with salbutamol. He has started on the MDIs, and incidentally, the child gets instantly better. In just a couple of minutes, the child is up and running and is free from the symptoms. And he was patting himself, thinking that he has done a good job. Unfortunately, this boy lands up in an emergency. Father says that, "Doctor, what have you done? My child is back in emergency. On that day, you gave the medicine. The child got better. But now my child is in emergency. What do I do?" Let's analyze what is this SABA alone treatment. In 1989, a case control study was reported that inhaled phenotrol, which is a short-acting beta agonist, was associated with an epidemic of asthma deaths that had affected New Zealand since 1976. This history underscores the importance of the frequent beta agonistic reliance without sufficient anti-inflammatory therapy, leading on to the emergencies which follow in due course of time. Pierce and Beasley presented this study way back in 1989. There is another study which was done in Sweden that is called the Sabina study, where they have brought out some important statements and recommendations. And that is SABA overuse, that is short-acting beta agonistic use of more than 3 canisters per year, occurred in about a third of mild, moderate, and severe individuals. And there was a significant group of individuals who were not optimally treated. And they had a very deteriorating effects following that. And individuals across all asthma severities remain at the risk of exacerbations when they continue to rely on SABA. So this underscores the importance that SABA should never be started standalone. Well, Dr. Expert is sitting in a quiet afternoon, and that's the time when all the medical representatives come and tell their stories. And they come up with this tulabitrol patch They say, look, doctor, this is not SABA. This is a long-acting beta agonist. A patient need not take syrups. Patient need not take the inhaled devices. All they have to do is to put a patch and they'll be done with the symptoms. As soon as that boy comes to his OPD, Dr. Expert just jumps and gives the medicine to him. And the story repeats. The boy is back in emergency this time, in a much severe fashion. What really went wrong? Let's analyze. There was this study which was published way back in 1998. And of course, many studies have been published thereafter where they observed that salmeterol, which is a long-acting beta agonist, controlled symptoms in the lung function until the inflammation became worse and significantly more advanced. And that's where they concluded that the bronchodilating and the symptom-relieving effects of the salmeterol can only mask the increasing inflammation and delay the awareness of the worsening asthma. The point what need to be underscored here is SABA should never be given standalone, LABA should never be given standalone, and that is where our Dr. Expert went wrong. So with the previous bad experiences, Dr. Expert became a little aware. He decides that the boy, Liam, should get better treatment. He started attending conferences, he started attending seminars, and this time he came across this ICS-SABA combinations. And which did help the boy to a certain extent. The boy certainly became a little better. But the question what we are asking today is, did Dr. Expert did the right thing or not? Let's analyze. Papai, in 2007, he published an article in NEGM. As needed, beclomethasone and albuterol in a single inhaler reduced the exacerbation and improved the morning peak versus as needed salbutamol alone. And they also observed that the cumulative doses of inhaled corticosteroids was lesser, demonstrating the evidence that ICS, when compared with salbutamol, did benefit the symptom control. And again, another study was published in NEGM again in 2022 by Mandela. In moderate to severe asthma on maintenance therapy, fixed dose salbutamol budesonide as rescue medicine reduced the time for the first severe exacerbation versus the salbutamol alone only or beclomethasone alone only. But there is this always tendency to observe that there are very less studies for pediatric specific population. Trexa's study was conducted which was published in 2011, where children between 5 and 18 years were studied. Daily beclomethasone reduced the risk of first exacerbation by 50%, which remains the most effective strategy to prevent exacerbation. They also added rescue beclomethasone, which reduced the risk by 33%, but not statistically significant. But a combined treatment gave no additive benefit over the daily or rescue alone. So this is one study. And there is another study. There are multiple studies which are available now that combining ICS-SABA and ICS-LABA does benefit, but is it fitting the regime is what we are looking at. Again, on a quiet afternoon when Dr. Expert is sitting in his OPD, he comes across with a medical representative who presents to him with ICS and a formoterol combination. What is this formoterol? He says that it is a rapidly onsetting medicine, but at the same time, it lasts for a much longer time. He does have to give 1 or twice a day and be done with it. As usual, Dr. Expert gets very excited. But this time, he exercises a lot of caution. He goes across to the GINA guidelines, he goes to the ATS, he goes to the British Thoracic Society guidelines. He reads everything about the molecule. This time, he's very confident. He calls Liam and says, prescribes the adequate dosages, adequate. He tells him that he has to take only through the spacer, and he also gives him a asthma action plan. So this time, though he is happy for his actions, Dr. Expert is pretty cautious this time. He's not overexcited because this is the learning curve, what he has gone through. He has gone from very bad experiences. He feels that he might have done a right thing for the patient, but father might criticize, the child may land up in emergency. But somehow at the back of his mind, he is very confident that the child will not end up in emergency. After the first follow-up, the child just doesn't come. He's lost to follow-up. Dr. Expert has become an expert. He's feeling bad that the child hasn't come back to him for the follow-ups. He's grown older. He's strolling in the park. He's doing his morning routine. A young boy comes up to him who's playing football and says, "Hi doc, how are you?" And then the father is standing next to him and he instantly recognizes it's the same Liam. The father is smiling ear to ear with a full grin. He's at glee. He says, "My child is the football captain. All thanks to you, doctor." For the first time, Dr. Expert is happy for the loss of the patient. Isn't it? It's such a satisfying and a gratifying thing to see. The child is getting better. The child is no longer coming to you for unplanned emergencies. If at all there is anything, it is just a planned meeting with the doctor. That's what we all want, an improvement in the patient's symptomatology. And that's what happened to Liam. Let's go through what's this MART therapy, maintenance and reliever therapy, which uses ICS and formoterol as both controller and reliever, which is this medicine has this nature of a rapid onset and having a long duration of action, which simplifies the regime and improves the adherence towards the patients. I think I have spoken about the origins of MART therapy in my previous videos. You can just go back and see that. I'll put a link of that video. Well, it was in early 2000s where the AstraZeneca company came up with this concept of combining this formoterol with budesonide in the name of Symbicort. That was a game changer. It made a huge difference in everybody's lives. It made the treatment regimes far and more simpler. And there are a lot of landmark adult trials like the Sigma trial, Practical and Novel Start. And there are meta-analyses which were published in 2018. They all consistently showed that the MART therapy reduces the exacerbation risk by around a third compared to the conventional regimes, reinforcing its inclusion in the international guidelines. And of course, the pediatric specific adoption recommendations were still in question, which needed a lot of robust evidence. It was Biscard et al. In 2006. He published this multi-center randomized double-blind evaluated trial. He evaluated children between 4 and 11 years with uncontrolled asthma. And they found that the MART regime resulted in 70 to 79% reduction in exacerbations requiring medical intervention compared to the fixed dose ICS or higher dose ICS therapy. with no significant difference in adverse effects. And children in the MART arm had a longer time for the first exacerbation, fewer severe attacks, and lower cumulative corticosteroid doses. So these things motivated the guideline makers to introduce this MART therapy in the international guidelines. It was first introduced in 2019 by GINA, UK, NICE, BTS, and SIGN guidelines. And our Indian Academy of Pediatrics, a national respiratory chapter, did not stay behind. We instantly adopted this formulation and we started recommending to our pediatric patients, which made a huge difference in the management. And the summary report on MART by the GINA guidelines, they say it very clearly that it reduces the risk of severe exacerbations, minimizes the SABA overuse, improves symptom control and lung function, and encourages anti-inflammatory reliever use. These are some of the specific benefits what MART gives you for our pediatric patients. Of course, this comes in standard doses of 100 micrograms of budesonide and 6 micrograms of formoterol, 100, 200, and 400, where the formoterol combination remains at 6 microgram. It comes in MDI, DPI, breath-actuated devices, nebulization, digital tracker devices are also available these days. But of course, not everything is honky-dory. There are some difficulties. The thing is, there is non-familiarity with the drug, dosing, availability, and the guideline recommendations. The guideline recommendations are much more streamlined today, but this is a statement which was taken in the past. Proper drug, proper device choice, and dosing is equally important for the understanding for the doctor as well as for the patient. And of course, there are some genetic variations where a child does not respond to the medicines. And anti-inflammatory reliever therapy, which is a ICS containing reliever, used whenever symptoms occur, most robustly as ICS formoterol in GINA track 1 across all steps, either reliever only in mild asthma or a reliever with MART at higher doses. So basically it is an umbrella concept where anti-inflammatory reliever includes as needed ICS formoterol at all steps, and some publications also describe ICS SABA as a AIR option within track 2 context. So the take home messages for this session is: in a diagnosed case of asthma, standalone short-acting beta agonist or long-acting beta agonist should never be recommended in any form. MART has the best safety and efficacy profile of any medicine used in asthma. The dosing, drug formulation, and the guideline recommendations have to be strictly adhered to. It is the theoretical and the practical aspects what differ with MART and AIR therapy, but the medicine what is used still remains the same. So with this, I'll be signing off. Thank you. Thank you for patiently listening. Make sure you hit the subscribe button and share this video as much as you can. This is an important video for all the practitioners who have been practicing pediatric asthma. Bye-bye. See you again in another video.